I am a leukodystrophy neurologist, but my PhD is actually in virology. And so my first love in the leukodystrophies was Aicardi-Goutières Syndrome, which is a weird cross-section of virology and leukodystrophies in white matter health. We have a really large work group as well, who's wonderful international collaborators. For those of you that are less familiar with Aicardi-Goutières syndrome, it's probably the second most common leukodystrophy after ALD, and it is a combination of 9 different genes. So it's a monogenic disorder, but really any disruption within the type 1 interferonopathy pathway can trigger AGS. And so people think that when you have AGS, your body thinks you have a virus infection, and particularly a herpes virus infection and those types of infections, which is where my PhD work was out of. And so it's a monogenic disorder, but it actually can affect multiple common pathways that all lead to increased type 1 interferon. So sometimes it's called a genetic type 1 interferonopathy. And so as we start to look for ways to intervene in AGS, it's actually a monogenic disorder that can do something that a lot of our other disorders can't do, which is drug repurposing strategies. And so we can steal from the rheumatology field, which affects adults and therefore has a lot more money than these rare genetic pediatric disorders. And so we can repurpose the adult rheumatology disorder drugs in a monogenic disorder that works through a similar mechanism of increasing type 1 interferons. And so currently our off-label use is using baricitinib, which is a Janus kinase inhibitor. We also occasionally will use anifrolumab, which is a monoclonal antibody that blocks the receptor binding as well. And I think this is an area of robust vigor as we are trying to figure out how to best stop this pathway, which you absolutely have to have, but you need in the right balance at the right times. And so unlike some of our disorders where really what you need to do is just replace something missing, for AGS, we're looking for a balance. I don't want to stop the interferon response. I just want to modulate it so people can respond appropriately to an infection, but not have that sustained constitutive interferon activation that's resulting in severe systemic sequelae. It was originally described in 1984 by 2 French neurologists, Aicardi and Goutières, who said it looked like a congenital familial disorder, like a torch infection, so a congenital infection. And in fact, that's the way many of our families are affected. But as we have learned more and we've started to do more broad-based testing, we're realizing that genotype-phenotype spectrum is huge, and not every single child is affected in the same way. And so that classic idea of a child presenting in the NICU with an infection that you can't find in the cerebral calcifications is really a gross oversimplification of how this very complex system that disrupts an entire network of immune response is impacting the brain and the whole body. The advances for AGS are numerous, so I apologize if I didn't pull your paper. I got tired. There's a lot of robust work, all the way from patient-facing case reports all the way through basic science and animal development. I think one of the challenges is many of our animal models recapitulate the molecular dysfunction, but not the immune dysfunction. And so if you fundamentally have a disease of immune activation, but you can't test it in animal models, that has been one big challenge. You look at our heat map, we're doing pretty good. I want to point out our advocacy groups. And so we have a representative from AGSAA, Devin and Rafa, down in the front row. And we have amazing families that represent a global community of families that are really desperate to engage in science and help move this process along. I think we have no approved medications, and that's been a challenge. I know many of our families are treated with baricitinib, which is the Janus kinase blocker, but one of the things we spent a long time talking about is how to improve equity and access for a drug that isn't approved and we're using off-label, and it helps, but it's not transformative in the way we're talking about with gene therapy. And so it's hard to measure small change. It's meaningful change to our families, but how do we convince payers that those small changes are really meaningful? We also are doing pretty well overall. We found that really one of our biggest challenges is newborn screening. And again, you're going to hear the earlier we diagnose these disorders, the better kids do. But when you have a disorder like AGS that has such a profound clinical spectrum where not even all children that have the molecular changes will have the brain disease, because we know adults that don't. How do you start a lifelong immunosuppression medication to prevent something that's theoretical? And I think with ALD, we have a beautiful monitoring system, which is a burden to families, but can detect the problems to initiate an intervention before there's irreversible damage. I think that's one of the challenges in AGS. We don't have that. I think we don't have multimodal therapies. One of the things we talk about time and time again, and it's starting to come up in this field, is we treat cancer and diabetes and hypertension with lots of medications. And when one thing doesn't work, we add on a second or we switch to another medication. Why do we think that these monogenic but inherently incredibly complex pathway disorders deserve just one treatment that should fix everything for everyone? I think that's very short-sighted, and we need to change those thinkings. And so what I want for AGS is for us to have a platform of drugs that we can personalize. Maybe your liver is your big issue, so we need to do a drug that works better in the liver. Or maybe it's a cardiac involvement, or maybe it's brain disease that we want to prevent. And so as we start to learn to have biomarkers and information that can help us to stratify systemic risk in AGS, it would be great to be able to personalize those medicines and target them. And I think the big challenge, as I mentioned before, for AGS is we have done a beautiful job with advocacy and outcomes and therapeutic development. It's really that approval process. As Simon has alluded to, clinical trials are hard. Approvals can oftentimes be even harder. And so how do you have something that has benefit and get it to the people that need it if you don't have the backing to get something all the way through? And so if I were to summarize, I think we're excited about newborn screening and we are working for ways to find it, but we don't yet meet the criteria to be able to stratify children at birth to understand what their future risk and how we would help support those families. And so in parallel with developing the assays, we need a better way to be able to prognosticate outcomes. And we need to improve therapies, multimodal, and also better understanding of how we do post-therapy monitoring. And so really, if I could say two things, genotype-phenotype correlation in AGS is going to be a huge challenge that we need to continue to work towards. And increasing benefit from interventions. So right now, we have baricitinib, which can help some, but we really need much more transformative therapies. But we also need to recognize that sometimes small changes are important and valuable to families, and therefore they should be important and valuable to us as providers too. And so it's understanding the risk-benefit of how we design clinical trials so that we can actually approve and move things forward for our population.